Hello, my name is Cheerag Shirodaria, and I am a consultant cardiologist at Oxford University Hospitals in the UK. I'm also the cardiovascular and metabolic therapeutic area head at Fortrea, and I'm the co-founder and chief development officer of Caristo Diagnostics, an AI imaging company. With me today is Chris Farina, CEO of Abcentra. Chris, would you like to introduce yourself?
Thanks, Cheerag. It's great to be with you today. I am Chris Farina, CEO of Abcentra. I'm a biotech executive and operator that has spent the past 12 years focusing on developing therapeutics within the cardiovascular disease space. I have been CEO of Abcentra for the past 2.5 years, where I've been focused on the phase 2A trials of ortikumab and the treatment of coronary artery disease.
Can you please tell us why coronary inflammation is gaining such attention as a potential therapeutic target for the management of patients with atherosclerotic cardiovascular disease?
Cheerag, I think for many years, inflammation has been identified as the underlying driver of cardiovascular disease. I think there has been an appreciation in this field that really all risk factors are driving inflammation in the vasculature, which is ultimately causing rupture of vulnerable plaques, which is the pathology of a myocardial infarction. Recent developments in the field have now allowed us to image that biological process more exquisitely than ever before. And I think that is causing a lot of excitement in the field, particularly in the identification of new targets and investigation of new drugs in the field, in a way that was not even possible 5-10 years ago.
As a cardiologist, Chris, we have many drugs available to us that we know reduce cardiovascular risk, ranging from very effective blood pressure lowering medications to antithrombotic and antiplatelet drugs, and also lipid modifying therapies. Do you still believe that despite the multitude of therapies that are available, there is still an unmet need for the way that we treat our patients with cardiovascular disease?
It's a great question, Cheerag. I think just to set the stage, in where I am right now, and where Abcentra is based here in the United States, there's 800,000 patients alone that suffer in acute coronary syndrome every year. The prognosis is still not good after an ACS. 1 in 5 patients will have a follow-up ACS within 2 years. And the brutal truth is that this is all occurring despite very good LDL control, lipid-lowering therapies, very good blood pressure control. There is just a lot of residual risk in this population. And so I think from a research point of view, the cardiovascular research community is looking to new mechanisms to help adequately treat these patients and really push the boundary of what is possible today, and give better outcomes to patients tomorrow in these groups that have a lot of inflammation despite the best standard of care available.
That's very interesting. So if I could just summarize what I think you're trying to say, Chris, I think what you're trying to say is that the residual risk, or the so-called residual risk that remains in patients who have their treatments optimized is primarily, well, firstly, it's significant. And secondly, you believe that it's primarily driven by inflammation.
Yes, I think that's a great summary, Chirag. And I would say, I think we believe that it's inflammation, but it's inflammation not everywhere in the body. It's inflammation in certain tissues that are associated with rupture and vulnerability of atherosclerotic plaque. And so those biological processes in those specific tissues, like the coronary arteries, we believe is what is driving residual risk.
So moving on to your particular drug, ortikumab, can you tell us a little bit about the background to ortikumab, in particular its putative mechanism of action?
Absolutely. Yeah. Ortikumab is a new experimental drug that is currently in phase 2B, a clinical trial that we have just started as of very recently, dosed our first patient in what's called the Fortify study. It is a fully human monoclonal antibody, IgG1 antibody, and it's against oxidized LDL. The way that it works is by it allows for targeting of inflammation in those inflamed tissues, because oxidized LDL is a key component in those inflamed tissues that does not exist in other healthy tissues. And essentially what ortikumab does is it uses oxidized LDL to hone to these tissues where there's inflammation, and it then quells pro-inflammatory macrophages directly in those tissues, but not all over the body. Its active form is only when it's bound to oxidized LDL, and it engages a specific receptor on the surface of a macrophage, which then inhibits that macrophage from secreting pro-inflammatory cytokines such as IL-1 beta and IL-6. And the key, Chirag, is that it does this in a very highly specific manner to inflamed tissues that have deposits of oxidized LDL.
And you mentioned, Chris, that it's an area of great interest, i.e. specifically targeting inflammation, and cardiovascular and coronary inflammation is a target that's of great interest to a number of companies and scientists at the moment. Obviously, we've seen impressive trial results from a variety of agents such as colchicine, canakinumab, and obviously there are ongoing trials with agents such as ziltivekimab. How does ortikumab differ from those drugs in the way that you're expecting it to work, and specifically how it targets coronary inflammation?
Yeah, so that's a very great question, Chirag. I think to set the stage, it's helpful to say that inflammation has been interrogated as a drug target in this field for now a number of decades. And there has been some seminal clinical work in the field that has really set the stage for this moment in time in a drug like ortikumab. So in particular, you mentioned canakinumab with the CANTO study, one of the first studies ever to show that if you inhibit a specific inflammation pathway, the IL-1 beta pathway, that without reducing cholesterol levels, you can achieve additional risk reduction in patients with a high degree of residual inflammatory risk. Building upon that, colchicine in the same vein with Colcots and Lodoco-2 have demonstrated in a number of cardiovascular populations that colchicine can inhibit inflammation and reduce risk. The issue with those first gen of inflammation drugs, in particular canakinumab, was the effect was accompanied by a hazard, a risk of infection, because IL-1 beta has a role, important roles in health, including in immune defense. And IL-6 inhibitors, I think the hope is that right now in phase 3, we'll see what happens in those programs. I think the hope is that we can see some of the hazard associated with the IL-1 beta therapies kind of ameliorated by giving low-dose IL-6 inhibitors. But IL-6 still very much does have a role in health, including in immune defense and cholesterol metabolism. So the way that I think about ortikumab, Chirag, and what Abcentra is trying to do is really usher in a next gen of being able to target inflammation in a plaque targeted therapy. So rather than inhibit inflammation mechanisms where your body does need these mechanisms to fight off infections and just host defense, for example, um, target inflammation very specifically in this context, in the arteries, in the tissue where there is pathology around plaque rupture. And so ortiguimab is the first of its kind, a plaque-targeted anti-inflammatory therapy. And as I mentioned before, it works by inhibiting these pro-inflammatory macrophages specifically in plaque, upstream of IL-6, upstream of IL-1 beta. This is a mechanism by which you can prevent secretion of an array of pro-inflammatory cytokines, not just one, and then target that response very, very specifically to an atherosclerotic plaque with oxidized LDL.
And that's incredibly exciting from a scientific perspective, because as you say, while we've understood for a number of years now that inflammation plays an incredibly important part in atherosclerosis and the pathogenesis of coronary artery disease, as you very eloquently put, Chris, our challenge has been that while we can inhibit inflammatory pathways, and in particular inhibit systemic inflammatory pathways, this comes at a price. That price, namely being immunosuppression, and hence an increased infection risk in our patients. So to hear that you have a drug that can potentially specifically target the coronary arteries, and indeed only target inflamed plaque, gives us great hope that we can achieve our holy grail of inhibiting vascular inflammation without unnecessary side effects that can harm our patients.
Well put, Chirag. I think as we get the word out about ortiguimab, the feedback that we've gotten from the clinical community and the research community is, especially in the physician takes very seriously the idea of doing no harm to the patient first. And I think the way that we think about ortiguimab is being able to give the patient and the physician a tool in the toolkit to show, to really interrogate that inflammation in the plaque, and feel confident that they're not interfering with other important biological mechanisms, is really why we're doing what we do at Abcentra. And we hope that it's a breakthrough that for many years can be something that the clinical community can use to treat patients for years to come.
And in terms of Abcentra's journey to developing a novel medication, indeed a first-in-class medication that specifically targets coronary inflammation, what have been the key milestones on your journey so far?
Yeah, so I think one of the most significant milestones along the journey occurred last year in 2024. We had just completed a phase 2A pilot study in patients with psoriasis. And previously prior to conducting this trial, I think one of the most challenging parts about this mechanism was getting confident that the doses that you're giving are active and effective. Because this mechanism is so specific for the coronary arteries, it doesn't lower your LDL cholesterol like a statin or a PCSK9 inhibitor. It doesn't lower your hsCRP like an IL-1 beta inhibitor or an IL-6 inhibitor. And so markers in the blood that we think about that are traditionally tied to cardiovascular risk are really not right for interrogating the doses of this drug. And so the significant part in our recent development history was in this pilot study that we reported the results of last year and published in the Cardiovascular Research Journal of the European Society of Cardiology, was that for the first time, we showed a potential to inhibit coronary inflammation using a brand new AI-based diagnostic imaging technique, which is reflective of inflammation in the coronary arteries, and linked, strongly predictive of residual risk of a MACE. And I think this has provided Abcentra and the orticumab program. It was a really seminal moment because it has provided us a pathway to select doses of orticumab that will have a high degree of confidence that they will be able to reduce risk of a MACE prior to initiating our phase 3 development.
And tell me, where are you at the moment on your journey in terms of development? You mentioned that you've completed a trial which showed some very promising results in reducing coronary inflammation.
Let me set the stage and say that in our phase 2A pilot study, we used a biosensor of coronary inflammation that can be measured on coronary CT angiography. And Cheerag, this is a technology for which you personally are a co-founder of the company that is working to commercialize a diagnostic around this important technology and this AI-based breakthrough that came out of Oxford University. And I see a lot of, for the last several years, the orticumab program and the ability to sense coronary inflammation have gone together. Would you tell us a little bit about the Caristo and this inflammation, this breakthrough in imaging of coronary inflammation?
Yeah, thanks, Chris. So as we've been discussing, we know that atherosclerosis is an inflammatory disease, but our challenge has been to develop biomarkers that specifically provide us with information about vascular inflammation and in particular coronary inflammation. Now, while there are a number of in vitro biomarkers that we can use to assess inflammation, such as high sensitivity C-reactive protein, IL-6, IL-1 beta, the challenge has always been that these are systemic biomarkers of inflammation rather than being specific biomarkers of coronary inflammation. Now, some important scientific and in particular basic science work undertaken by colleagues at the University of Oxford over the last decade has really shed some important light on this disease process. So really starting from the bench work that was done here in Oxford, what was shown was that when you have an inflamed coronary artery, inflammatory cytokines are released from that coronary artery or that inflamed vessel, and they cause morphological changes to the surrounding adipose tissue around the vessel, the so-called perivascular adipose tissue. And what the basic science work here in Oxford showed was that the adipocytes or fat cells that surround the coronary artery, in response to an inflammatory stimulus, they change their phenotype. And what we see is that adipocytes become smaller and the ratio of fat to water content changes. In short, the adipocytes become cachectic. And essentially, one could describe atherosclerosis as a chronic cachexia. Now, we're very familiar with cachexia in cancer patients. And we also know that atherosclerosis starts in adolescence. So what appears to be happening is that when you have an inflamed coronary artery, these changes occur and cause phenotypic changes in the surrounding adipose tissue. Now, the really important breakthrough that was made from there was, and indeed the question that was posed was, now that we've identified these phenotypic changes that occur in adipose tissue ex vivo, is there a way to visualize those changes in vivo, i.e. in a patient? And it turns out that coronary CT angiography is the ideal imaging modality that allows us to visualize these phenotypic changes in perivascular adipose tissue. And essentially, these changes in adipose tissue phenotype manifest as attenuation changes in the perivascular adipose tissue that we can capture on a routine coronary CT angiogram. So in short, changes in perivascular adipose tissue are a are an imaging biomarker of coronary inflammation. So in other words, a specific biomarker that tells us what's going on in the coronary arteries in response to these inflammatory stimuli.
That's fascinating. And it's quite a big breakthrough in the sense of never before have we been able to look directly into the coronary arteries as close to the pericoronary adipose tissue to get information about specifically the amount of inflammatory burden in these vessels. But I think one of the things that makes this breakthrough particularly interesting is its ability to predict risk of cardiovascular death and MI. Could you tell us a little bit more about how that was made possible using the resources through Oxford University and the NHS with the Orphan study?
So the initial work that we undertook here in Oxford to show this link between inflammation and changes in perivascular adipose tissue composition and attenuation on imaging answered the first question that there is a link. In other words, that we can visualize these changes. But the key question that was asked after this first paper was published in Science Translational Medicine was, so what? And the so what is, well, it's great that you can visualize and quantify coronary inflammation, but the unanswered question at that point was, does this predict future risk of cardiovascular events? And in order to answer that question, what one needs are robust data sets that not only have imaging data from patients or from a broad background, but also have the linked outcomes data. In other words, what happens to these patients. So the Orphan Registry is a University of Oxford sponsored registry led by my colleague Harris Antoniadis. And Orphan is the largest CCTA registry in the world. It aims to have over 250,000 images with linked outcomes data. It already is well on the way to reaching that goal. But what we've published over the last few years have been some important data from the Orphan Registry showing this link between these changes in coronary inflammation or perivascular fat inflammation, and we call that imaging biomarker the Fat Attenuation Index, or FAI score. And what we published last year in 2024 in the Lancet was data from the first 40,000 patients in Orphan. And what we showed was that those patients who have the highest degree of coronary inflammation, in other words, the highest FAI scores, have a significantly increased risk of not only cardiovascular death, but also of major adverse cardiovascular events such as myocardial infarction and heart failure. And to give you an idea of the degree of risk that patients have, we're talking about at least a 10-fold increased risk of cardiovascular death, and that's over a 10-year period. And the patients in question in Orphan have undergone a clinically indicated CCTA for a variety of reasons, many of them for chest pain evaluation, many of them for if they have a strong family history of coronary artery disease. But the key thing is that the linked outcomes data associated is extremely robust because it's in the UK, which provides the greatest bulk of patients in Orphan. That clinical outcomes data comes from national registries. So it's a comprehensive data collection from the UK National Health Service.
So for the first time, coronary CTA is now providing a new piece of information that was not previously available to the clinical community, which is the amount of inflammation in the patient's coronary arteries and what that means to the patient in terms of additional risk on top of the traditional risk factors.
That's right, Chris. And I think that's a great place to wrap up our first episode on the evolving science of coronary inflammation. We've explored the biological underpinnings of inflammation in atherosclerosis, the unmet clinical need despite current therapies, and the exciting potential of targeted approaches like ortikumab. In our next episode, we'll dive into the practicalities of drug development, how we bring these molecules through clinical trials, the challenges we face, and the opportunities that lie ahead.